Well, it's a beautiful day here in the Boston, like Charles River, right next to the community boating. And I figured I would do a little video for you guys on a recent case that I saw just this past week. The patient that I had originally treated in the year 2010 with hydraulic condensation. And this is an old patient that has been coming back a couple of times with different things. And he actually had rather 3 teeth that I treated that I think I want to talk to you guys about in this video. And the first one's a root canal that I did on his first molar in 2010. And then he returned for a root canal on tooth number 15, which was the second molar, maxillary second molar, just last week. So we ended up having a 12-year recall on it. And I would like to talk to you about that. And then I'm going to talk to you about a resorptive defect that I repaired on his canine, both non-surgically first and then surgically, and how that turned out now after a few years of recall. So take a look at this case first with a non-surgical root canal therapy.
So this was a case of hydraulic condensation that I did in 2010, and the patient at the time was having irreversible pulpitis in this maxillary first molar, as you can see here, under a crown, and was in for root canal therapy. And so we went on and found 4 canals on the tooth and treated it using conventional endosequence technique. At the time in 2010, I was using basic endosequence protocol and hydraulic condensation, which we had just developed about a couple years earlier in 2008. And this patient was done in a single visit, and the access in the crown was filled, and the patient returned back in 2020 with a chief complaint of some discomfort in the maxillary second molar area. And we did some testing. We found out that the source of the pain was actually the maxillary second molar, in which he had continued thermal sensitivity and issues with the tooth. And the tooth number 14, or the first molar, was completely asymptomatic. And radiographically in the PA area, you can see that there are no problems associated with it. So we ended up having a 10-year recall on this hydraulic condensation case, and that was very nice. But his sensitivity in the maxillary second molar did not end here. So after replacement of the amalgam filling that he had in there and placement of a bonded composite, the pain to cold as well as the chewing continued. I assumed that there was maybe a small crack underneath the original amalgam that was causing these symptoms, and the patient had continued symptoms in the tooth. Now, as you can see here, that the pulp is far away from the restoration, but the symptoms were present, and I validated that clinically. So we took the pan in 2022 when he decided that he wants to have the root canal, that he can't continue with the same thermal sensitivity on the tooth. And in the pan where we were looking at the second molar, I also got a chance to look at the healing that was taking place on the first molar. And you can see here that we had these 4 canals treated about 12 years earlier using hydraulic condensation. And now having this 3D image of the tooth, we could see the healing at the apex of the tooth. You can see that we have complete area of continuity in the lamina dura and the bone right at the apex of this tooth, following this long-term presence of the hydraulic condensation with the interface against the BC sealer. Again, helping me know that the hydraulic condensation technique is a valid and a viable technique in the long run. So this was not about this tooth. We were kind of taking a look at, actually, the reason we did the CBCT on this one was to look at the second molar. And you can see the second molar, if we look at the axial section, it's one of those teeth where the mesial root is kind of ribbon-shaped. And these are very, very challenging. And one of the main reasons for failure is because this ribbon, you can see the MB1 and the MB2 right in the middle of this ribbon area of this fused mesial buccal root, is fairly difficult to kind of find the MB2 because it's fairly thin, and we can see that it does separate towards the apical third of the root into 4 different canals. So that's what we know that ahead of time, and that's thank God to CBCTs to give us that information, because as you can see, the MB2 in this particular case is fairly lingual off of that mesiolingual line where the MB2 would normally be found. You know, based on the Coolidge study, we've been looking at about a couple of millimeters from the MB1, but this is more like 4 millimeters or longer. And when we get to do our clinical access in the crown, and you got to give yourself an adequate access in these types of cases, you can see that the MB2 is fairly lingual here, and I'm searching fairly close to the paddle canal for the MB2. I'm now using the E15D ultrasonic tip, which gives me a little better chance for visualization. Now, I always use this with water, and the reason for that is I never use my ultrasonic tips dry, because you do need the water to flush out the debris that you cut. It gives you a far better and cleaner canals, and it helps remove any of the free-floating materials to get stuck coronally or fall into the canal. And you can see now we have the 4 canals. We've searched deep on the mesiolingual line to find the MB2 in this particular case. And we continue so that here at the end we have done our hydraulic condensation, and we have our 4 canals obturated using the same technique that 12 years ago I did on the tooth in front of it for him, to have isolated and localized these canals, and have used now the endosequence blend protocol in this particular case. And you can see in the post-op radiograph we have immediate post-op on the tooth, that we have found all 4 canals and instrumented them. On the parallel route, there is a post base that I prepared using the old drill-less post preparation technique, the so-called the Nasseh post preparation technique that I described back in 2008 with hydraulic condensation, in which you actually prepare the post base at the time of obturation. You fit your post before you actually obturate using hydraulic condensation, and you segment the gutta-percha at that point. So it allows you to have a very quick post-preparation. You can see the video that I made on that in one of the links below. And so we decided also, as this patient was so nice, having seen me for so long for so many different procedures, to let me do a post-op CBCT on this tooth, so that we can make sure that we did achieve proper lengths and so on the MB2 as well. And we found it, and how does it look on the radiograph? And so we took a post-op CBCT looking at these sections on the sagittal to show the paddle, and then the MB2, MB1, and the distal buccal right over here, as you can see, are filled right to the proper length. And this working length determination in these cases, I use the EndoSync Plus, which is now my trusty little handpiece with the using my EndoSequence Scout files to measure the length with. And you can see here now in the coronal section, the MB1 and MB2 are filled and the paddle post space is prepared. And now we're going to go down the axial section to show how in this case I did not put the BC liner, because the referring dentist had actually requested a post space on the paddle root. Now, I'm not sure if a post space is really required in the second molar, where you still have so much remaining tooth structure, but I'm not going to argue with the restorative dentists over this if that's what they want. So, especially if you're using a fiber post, as they are with this, as I always send them the fiber post for the endosequence technique, it's really not going to necessarily cause any harm, but anyway. So this is it now, the 3-dimensional shape of the MB1, MB2, and the paddle root with the post space. You can see that they are prepared, and we managed to find the MB2 along that fused mesiobuccal root. And we'll continue to monitor this, and hopefully we'll have another 10-year recall on this for you guys later on.
All right, so as you saw, it's at least kind of reassuring to know that hydraulic condensation after 12-year recalls, and of course I have so many of these nowadays that they all back from multiple other root canals and other teeth, and I get a chance to follow up on them, that when you do follow the principles of proper root canal therapy, you can get actual good results and follow-ups that work in these kinds of patients. It's just all about finding all the canals, getting down to the canals, and then having an adequate apical preparation, and of course having proper coronal seal to prevent leakage on top is also very helpful for long-term standing of your cases. But of course having the right type of material and cement that has that kind of long-term durability is also an important factor. To that extent, it's important to know what kind of material you're using. All right, I did also a pair of invasive cervical root resorption on this very same patient a couple of years back, and then I did that non-surgically first, and then followed that up with a surgical repair using BC liner. What I'm going to do is, so to make this video short, I'm going to do that second segment in the next video for you guys. So stay tuned, come back for the next video where we're going to talk about invasive cervical root resorption on a canine.